Welcome to the 37th DeVos Medical Ethics Colloquy. My name is Tricia Thomas, and I'm the Dean of the Colloquy College of Nursing, and I'm delighted to be with you here this evening. With the College of Health Professions and the College of Liberal Arts, the College of Nursing, we are actually delighted to serve as the hosts of these colloquy events. The topics covered in these dialogues impact our interprofessional healthcare providers, faculty, and students, those serving in the community, and those that are learning in our community. We are pleased to provide the platform to continue these events and plan to join you in these discussions. If you're interested in receiving CME or continuing ed for nursing or social work, please make sure to sign the sign-in sheet outside the door to the right here on the table. And you will also find, as a point of logistics, a card on your table. We will be gathering these cards for question and answers at the end of this event, the last 30 minutes, which will be provided for that conversation. I offer special thanks to our Colloquy Planning Committee for their ongoing support and leadership of the DeVos Medical Ethics Colloquy. And we'd also like to recognize and thank this evening the principal sponsor, Corewell Health, and our major sponsor, Trinity Health. I also want to acknowledge Jill Smalden, who is our event planner. She is the Director of Communications and External Relations in the College of Nursing. It is my pleasure to offer introduction of Dr. Paul Farr, our DeVos Colloquy Advisor Committee Secretary, who will offer opening remarks. Dr. Farr is a retired gastroenterologist from Trinity Health St. Mary's and a community volunteer. Dr. Farr.
You're applauding Dr. Thomas, not me. Welcome here. This, like Dr. Thomas said, this is our 37th biannual colloquy. And this was started by these two gentlemen. It was actually Rich DeVos sitting down, thought of this in 2004 and asked his right-hand man, Dr. Luis Tomatis, who's standing, to start the colloquy and start recruiting speakers. Like tonight, we've got two speakers, both incidentally from Chicago, but both very talented, very nationally known, and good discussion will ensue. I want to thank Dr. Thomas, and Jill Smalden, but also a person that's sitting to my right, Dr. Burns, who is our intellectual leader, and without him, we wouldn't be picking all these fancy topics. So, without further ado, I'd like. Am I right?
Yes. Okay. Perhaps. Great. Thank you all for coming. It's my great pleasure to introduce my colleague and friend, our moderator, Dr. Matt Armstrong. Dr. Armstrong is, among other things, an anesthesiologist, critical care physician. He studied zoology. Nobody's perfect, and developed an interest in philosophy while attending Miami University in Oxford, Ohio. He matriculated at Michigan State University College of Human Medicine, where he was able to co-enroll as a bioethics master's degree program. Dr. Armstrong graduated with his Doctor of Medicine and Master of Arts in Bioethics, and he completed his anesthesiology residency at the Mayo Clinic in Rochester, Minnesota. His critical care fellowship at University of Washington in Seattle, and prior to joining the anesthesia practice consultants group in Grand Rapids. In his professional capacity, Dr. Armstrong has attended patients in the cardiothoracic critical care unit of the Meyer Heart Center and the operating room at Butterworth Hospital and beyond. He's involved in medical ethics and medical ethics education at the medical student, resident, and fellowship levels. Dr. Armstrong now serves as the chair of Bioethics Committee at Corewell Health West. Welcome, Dr. Matt Armstrong. Thank you for being a moderator.
It is an honor to be here with you all tonight. Thank you for coming in person. It's my absolute pleasure to introduce our speakers. First is Dr. Daniel Brudney. Dr. Brudney is a Florian Hugh professor in both the Department of Philosophy and the college at the University of Chicago. He's also associate faculty in the McLean Center for Clinical Medical Ethics, and he's the associate faculty at the Divinity School. He writes and teaches political philosophy, bioethics, philosophy, and literature. He's the author of Marx's Attempt to Leave Philosophy, which was published at Harvard University Press. And his recent publications include The Theory, Rawls, the 1844 Marx and the Market, and Nostromo and Negative Longing, as well as Decisional Capacity, Two Philosophical Problems. Please help me welcome Dr. Bredney. Our second speaker, is Dr. Aaron Paquette. Dr. Paquette is an associate professor in the Northwestern University Feinberg School of Medicine, the Department of Pediatrics, and the Northwestern University Pritzker School of Law by courtesy. She's also an attending physician in the pediatric critical care units and is the chair of the Ethics Advisory Board and director of clinical and organizational ethics at the Anne and Robert H. Lurie Children's Hospital of Chicago. A member of the steering committee of the Northwestern University Institute for Public Health and the Center for Bioethics and Humanities, and she's a founding member of the President's Council for Equity, Diversity, and Inclusion, where she co-chairs health equity activities for the hospital and is a member of the steering committee for the Health Equity and Anti-Racism Center at Lurie Children's. Please help me welcome Dr. Paquette. Thank you both for being here. And now, without further ado, Dr. Bredney.
First, thank you for inviting me here. It's really a great pleasure to speak to you tonight. And I guess I should say thank you for putting up with me. I am a philosophy professor, and that means that what I talk about are things that are rather abstract. I hope they will be clear. They aren't always. But I hope their relevance to clinical ethics at the bedside will become clear. But especially, I probably won't take up all of my allotted time, which is really good because then there's more time for questions. And that's what philosophy started out and still is at its best as questions and answers, not as lectures. So bear with me while I lecture for a while, but then the real stuff comes when you guys get to ask questions. Thank you. Okay, so here's the outline of the talk. As you will see, we'll be talking about the concept of agency and authenticity, two ways of thinking of the concept of autonomy. But let's move first through this. So the question of whether one should ask for pediatric medical assent, and that is my title today, that's my topic. But it's also a question about assent in any medical context, pediatric or adult. It might seem to be a misguided question. After all, the criteria for decision-making capacity they're not arbitrary. There's some debate over those criteria. These are some standard ones. But the scope of disagreement is relatively modest. I doubt that there's fundamental disagreement about whether the standard criteria of decision-making capacity, those proposed by Applebaum and Grissom, for instance, do successfully identify most patients who are capacitated, and if current criteria do successfully identify patients who are capacitated, and therefore also those who are not capacitated, one might think that should be the end of any issue about who should get input into the medical decision. Those who fail to meet the criteria don't have decision-making capacity and so should not get input. And by hypothesis, anyone for whom we are seeking assent rather than consent does not have capacity. So here we should ask what decision-making capacity is actually testing for. My proposal is that it's testing to see whether a patient has a threshold level of what philosophers have called practical reason. This goes back to Aristotle. He's the first to distinguish between practical and theoretical reason, and the distinction is a fairly straightforward one. Theoretical reason involves reasoning about the way the world is, about how to move logically, say, from thesis A to thesis B. Math and science are the standard examples of such reasoning. One uses deduction, the other induction, but both are well-developed forms of logical reasoning about the way the world is. By contrast, practical reasoning involves reasoning about what to do. Of course, any good exercise of practical reason starts with a grasp of part of the world, with how the relevant things are. Moreover, practical reasoning has to move logically. Still, determining how things are in the world and determining what to do in light of how things are constitute deeply different activities. Now, if a patient doesn't have decision-making capacity, then she fails to pass a threshold of practical reason with regard to a specific medical decision. And so back to the original question, if such a failure disqualifies the patient from making the decision, why shouldn't it disqualify the patient from having any input into the decision? Yet clinicians often have a strong intuition that this or that patient, often in the pediatric context, but not exclusively, who lacks decision-making capacity should have some kind of input. And I think they're not merely worried about finding a pragmatic strategy to avoid patient resistance. In seeking patient assent, they believe that a moral issue is at stake. So what can justify this intuition? I think we can see a justification if we distinguish the different elements of practical reason as they bear on medical decision-making. I think we use an unduly narrow conception of practical reason in thinking about medical decision-making, or that's what I'm going to argue. We can start by noting that the usual criteria of decision-making capacity, say these, ability to communicate, ability to understand information, ability to appreciate the nature of the situation, and ability to manipulate information rationally. These derive from a very specific philosophical tradition, whose most famous advocate was the Scottish philosopher David Hume. This tradition sees practical reason as essentially what might be called instrumental reason. To be practically rational on this view, it's sufficient to be able to grasp what the facts of a situation are and then to be able to reason both deductively and inductively to conclusions about other possible facts. That's what seems to be going on when a patient is asked to understand her medical situation and to understand that one kind of treatment, call it treatment 1, might lead to one kind of outcome 1, while a different treatment 2, might lead to outcome 2. Note that on this picture of practical reason, the relevant ends are taken as given. I start at point A, a desire to get to point B. If I'm practically rational, I figure out how to do so successfully. Or, if the world is against me, I figure out that it's not possible to get to point B. Either way, on this conception of practical reason, my desire to get from A to B is not something to be assessed by reason. It's merely the starting point for my reason. In a treatise of human nature, Hume remarks, "'Tis not contrary to reason to prefer the destruction of the whole world to the scratching of my finger." Hume's claim is that a preference or a desire, and I'm going to take those two things, preferences and desires, to be the same, is not the sort of thing that is properly assessed as either rational or irrational. He thinks they can be assessed as good or bad. He thinks preferring the destruction of the world to the scratching of your little finger is bad. But what he's saying is, it's not irrational, because a preference is not something to be assessed one way or the other by reason. He says to have a preference is no more to be subject to rational assessment than how tall you are. That's his metaphor. So the first thing I want to stress is that although the conception of practical reason that I think is baked into our current criteria for decision-making does derive from Hume, this is far from the only conception of practical reason that one finds in the Western philosophical tradition. On the contrary, this conception was a complete outlier until the 17th and 18th centuries. No one took this seriously. Even now, at least within the Philosophical Academy, it's very far from the dominant view. So one thing to do is to start by saying we should not assume that our current criteria of decision-making capacity rest on sound philosophical footing. They very well might not. Second, I want to stress that we need to distinguish between the criteria for determining decision-making capacity and the value of having such capacity. If you satisfy the criteria for capacity, you're allowed to make your own medical decisions. This means that you're allowed to accept or, crucially, to refuse any medical treatment, including life-sustaining treatment. Why is that the right thing to do? Why is that the right way for us to structure clinical practice? What's the value, or what are the values that are being instantiated by allowing patients to make their medical choices? Another way to put the point is that to satisfy the criteria for capacity, that's something that will invest in the patient a major moral power. However, the current criteria are merely about having a certain kind of reasoning ability, what I've called instrumental reason, that in some cases is going to enable you to know where to park without getting a ticket, right? You want to park and you don't want to get a ticket, you figure out how to do it. That's instrumental reasoning. In other cases, it's going to enable you to tell a clinician to begin a process that you know will lead to your own death, such as removing a ventilator. In both cases, in terms of the rational abilities that you have that give you this moral power, all that you have are the abilities to recognize facts about the world and to engage in the logical procedures of deduction and induction. So we ought to ask, what's so great about this? Is the exercise of these particular abilities so wonderful that it warrants allowing patients foolishly to refuse life-saving treatment? As it happens, I'm reasonably decent at math and science. Why does that make it morally appropriate to permit me to refuse life-saving treatment? In a useful article, Mark Navin and Jason Wasserman argue that the reason to ask for pediatric assent is that children are often capable of forming and articulating what Navin and Wasserman call preferences. Now, I think there's something right about what they're saying, because they're urging that having a different kind of capacity from just the capacity for math and science, capacity to have a preference, is potentially a reason to allow input into medical decisions. I think this is on the right track. Still, more needs to be said. In particular, a preference or a desire doesn't seem to be sufficient to underpin the right to make a life and death decision. My dog has preferences, but he shouldn't be allowed to make his own life and death decisions. So we need to try to figure out what's going on as to why we bother to let people make these decisions, what it is to think that people are capacitated when it must go beyond merely being able to do math and science. So here I want to turn to the concept that you all know about from medical ethics called autonomy. It's often said that when we let a patient, it's often said that when we let a patient who has decision-making capacity make a medical decision, we're respecting the patient's autonomy. This doesn't tell us much at all. The term autonomy merely functions as a label for something of value without telling us what that thing or things of value are. So to see what values might be at issue, I want to look at two hypothetical examples. So the first comes from a book by Mark Siegler on clinical ethics. It is this. Patient 1 is a 24-year-old graduate student. He comes voluntarily to the emergency room. Previously in excellent health, he's complaining of a severe headache and stiff neck. Examination of spinal fluid leads to a diagnosis of bacterial meningitis. Administration of antibiotics is recommended. When he's told his diagnosis and that he would be admitted to the hospital for treatment with antibiotics, the patient refuses further care. The physician explains the extreme dangers of going untreated, serious risk of death or permanent disability, and the minimal risk of treatment. The young man persists in his refusal, citing merely the fact that he deeply hates shots. Other than this strange aversion, he exhibits no evidence of mental derangement or altered mental status that would suggest decisional incapacity. So that's patient 1. Here's patient 2. She is a 56-year-old devout Jehovah's Witness. She has read broadly in and believes deeply in witness theology. She's lived her life in accordance with witness precepts, and she sees a substantial part of the meaning and value of her life as tied up with her witness identity, and so with compliance with the requirements of that identity. She now needs a major operation in order to survive, but the operation cannot be done without significant use of the kind of blood products that witness theology, or at least the kind to which she subscribes, proscribes. So she's refused the operation. Now, note about both cases, it's possible to save the patient's life by compelling medical treatment. There's nothing medically mysterious going on. When asked, and I use these examples when I teach clinical ethics fellows, some of them think that it would be morally justified to administer antibiotics to the graduate student without his consent. I always sort of spiff this up. There you are, you're really good at giving a shot. The graduate student is dozing. He'll never even notice it. You're walking by on your way to some other clinical activity, and you could just, he's going to die if you don't do this. You walk by, you just, yeah, and on you go. And I ask people, how many of you think that would be the right thing to do? How many of you think that would be the right thing to do? Nobody? How many of you are sort of tempted? Oh, we've got somebody who's tempted. Now, let's turn to patient number 2, the Jehovah's Witness. Of course, compelling an operation is it's a bigger invasion of the body. It's a more complicated thing. How many of you, though, even if you could do this, are at all tempted to compel treatment of the witness? Now, I think there's a reason why people tend to be troubled by both cases. Both cases are very sad. But people tend to wonder about the graduate student as to whether or not, oh, come on now, what's the big deal? Just a quick shot and on we go, where they think there would be some kind of profound violation with the Jehovah's Witness. And that's what I want to look at. In the first case, with the graduate student, I think that all that's going on is that you're violating what I'm going to call the patient's agency. Patient's right just to make a choice. With a witness, you're of course violating her agency, but you're also doing something else. You're violating, indeed deeply undermining, what gives her life meaning. You're violating a term which I don't like, but I hear it in clinical context, her authenticity. I often hear doctors in clinical context asking whether the patient's choice is authentic. Now, partly they sometimes mean, is the patient really alert and focused? But often what they're trying to get at is whether or not this choice fits with the larger set of values that the patient has. And my thought is that it's worse to violate someone's authenticity than it is to violate their agency. And that's why we at least have one person who might actually give that graduate student the jab. But I take it you're not going to think seriously about compelling, maybe? No. The witness have her operation. So here's the distinction. Human beings make choices, and one might think that there is something offensive about restricting just about any human choice. That's the idea behind the teenagers assertion. How many of you have teenagers or remember having teenagers? Or remember being a teenager? Yeah. You're not the boss of me. That's what the teenager says. And but lots of choices are trivial. So if I tell my child, no, you can't have a second piece of chocolate cake, that doesn't ramify. And many of our choices, indeed probably most of them, are sort of one-offs. But there are also choices that are part of what Bernard Williams, a very great philosopher, called ground projects. And a similar way, another philosopher, John Rawls, talked about as a life plan. This is the thought that human beings don't just make individual choices. We have plans. We have projects. We do things that extend over time and that we think have a certain kind of coherence and that are tied to our values, to how we want our life to go. And those are both important things. Making choices, even individual choices, and having projects. But I think they're different. And I think that when we're talking about autonomy in clinical contexts, what I think is really going on is that we're talking about both of these things. We're talking about agency and we're talking about what I've called authenticity. Each of these is valuable, highly valuable, but they are different. So let's just say these are two different conceptions of autonomy. Autonomy as agency and autonomy as authenticity. And that's what I think is going on in the adult context when we're actually ready to say that it makes sense to let someone refuse life-sustaining treatment. Because if we don't, and the key here really is authenticity often in that context, if we don't, we're violating the meaning of that person's life. And that's a value which we can actually think might be indeed the very meaning of saying that we let people refuse life-sustaining treatment is we think that's a value that's more important than human life. Okay, so now for a couple of asides. One is analytical, philosophical, one's historical, or rather two are historical. The analytical one is that having decision-making capacity is not a condition for having at least some degree of the capacity for authenticity. Here I'm going to keep to the adult setting Agnes Jaworska, in a very fine paper, gives an example of an elderly man with a considerable degree of dementia who wishes to buy a pickup truck. Indeed, he went out and bought it. And then it had to be returned. He clearly didn't have agency. He clearly does not have decision-making capacity, but he does have a reason for wanting to buy the truck. It's part of his picture of what a man is, what the good life for a man involves. Jaworska quotes him as saying, "A man needs his truck." Now, this is about what for him an authentic life is. And it's about his vision, really, of a good life. And here, this is just to say that you don't need to have decision-making capacity to have some components of what makes capacity valuable, namely to have an element of authenticity. This man's all things considered best interest do not entail buying the truck. His decision-makers are right to refuse to let him do so. But something is lost when he is forced to return the truck. There is a loss to him, and it's a loss because he has a certain vision of how life should be lived. Now, the next two asides concern the history of the concept of autonomy. I'll be brief. To begin with, the idea of placing great value on either the capacity for agency or the capacity for authenticity is not something that's always been part of the Western intellectual tradition. Plato would have scoffed at this idea, so would Aristotle. We can debate whether the root of our current beliefs about these matters first sort of starts to percolate up with the Stoics, with Augustine in the 4th and 5th century, the Common Era, in the Renaissance and so forth. Historians can try to figure that one out. What I want to point out is that our current beliefs that say that agency and authenticity are valuable are relatively recent. Even if they go back as far as the Stoics, they don't go back 3,000 and 4,000 years. And that doesn't mean we shouldn't hang on to it, but it does mean that we should be aware that they're not all there is. Another way of putting the point is that these are formal capacities. I exercise the capacity for choice just as much when I make a bad decision as when I make a good decision. And authenticity can be a feature of a life plan that's foolish or even pernicious. Plato and Aristotle have accounts of what makes a human life a good life. Each would say that the key is simply to get the content of a good life right. The idea that there's considerable value in these formal features of action, agency, and authenticity is a relatively modern one. So my last aside concerns the role of the historical aside concerns the role of Immanuel Kant's text with regard to the concept of autonomy in clinical ethics. You guys who do health ethics, you associate Immanuel Kant with the concept of autonomy? Yes? No? Yes? And that's both right and wrong. The word autonomy is a combination of two Greek words, auto or self and nomos or law. To be autonomos is to give oneself the law. But prior to Kant, the term was used with regard only to political entities. For instance, the Renaissance city-state of Florence might have been autonomous in the sense that it was not subject to the power of Rome or Milan. Florence made its own laws, gave the law to itself. Kant, in 1785, was the first person to apply the term to an individual action or to an individual person who's doing an action. So it is historically correct to associate Kant with the current uses of the term autonomy in medical ethics. But what Kant himself meant by that term is very different from what medical ethicists mean by it. What Kant means, Kant calls an action autonomous if it's motivated not by reference to the person's desire or preference or life plan, but solely by reference to the requirements of the moral law. Whereas actions that we talk about as autonomous at the bedside are almost without exception merely ways of talking about the fact that the patient is trying to satisfy a preference or desire, or trying to pursue a project or a life plan. Being subject to the constraints of the moral law might come in, might not. It's not what we mean when we talk about autonomy at the bedside. So in one sense, although Kant came up with the term for talking about human action, we use it in a way that he would frown upon. But there's another way in which he would be right on target with at least the notion of agency. He finds great value in our capacity to make choices. what I've called our capacity for agency. He calls this capacity the capacity to set an end. He goes so far as to say the capacity to set oneself an end, and interestingly, he says any end whatsoever, is what characterizes humanity as distinguished from animality. Now, his thought here is that, and I'm going to continue on in a bit, is that it's very special thing that human beings do when we act, that we do something different from animals. Animals just are pushed around by causes, Kant thinks. We actually make decisions. I want to come back to this in a minute. Turning to what I've called authenticity, its central recent champion is, in fact, not Kant, but rather a different philosopher from the 19th century now, John Stuart Mill. And if you want to sort of see the modern intellectual root of this idea, take a look at chapter 3 of Mill's book on liberty from 1859. He thinks that a fundamental part of a good human life is to lead it in accordance with one's own deeply held beliefs and values. So we have then two ways of thinking about why patient choice is valuable. One descended from Kant, agency, and one descended from Mill, authenticity. I want to turn now to the pediatric context and now maybe get to the issue of assent. And let's start with agency. It is connected to the idea of a preference, and so this returns us to Navin and Wasserman's point that a pediatric patient can have a preference. They think that this is a valuable capacity that should be taken into account in pediatric decision-making. For them, the value of the capacity to have a preference is the basis for the value of pediatric assent. So we got to look more closely at this idea of a preference. When Kant accords value to agency, he is according value not merely to having a preference or a desire, but to something considerably more complicated, namely not just to engaging in a physical motion at the behest of an urge of some kind, but to acting for a reason. That is, when he talks about setting an end, he thinks you set yourself an end for a reason, or as he would put it, for a sufficient reason. So, let's say I set myself the end of drinking a glass of orange juice. Why? Why do I do that? Well, I think orange juice is delicious. I might think that's a sufficient reason to go pour myself a glass of orange juice. I also think it's nutritious and I want to be healthy. I might think that's a sufficient reason. The point is that if you want to explain what Brudney is doing when drinking a glass of orange juice, you're going to have to make reference to why Brudney is doing it, to what Brudney thinks he's getting out of it, what Brudney's reasons for doing this action are. The Martian scientists who can look down and peer into my brain will give a very different explanation. The Martian scientist will give a purely causal explanation. The Martian scientist will note that I've got brain states, and these brain states cause other brain states, and the brain states cause motions, and these motions might cause other brain states, which cause other motions, and so on and so forth. There won't be any reference to my reasons. There will just be reference to a causal chain. Now, lest you think that Kant doesn't see the importance of causal chains, his first great work, The Critique of Pure Reason, was written entirely to defend the proposition that natural science can give a completely deterministic causal account of everything in the material world, including human action. But Kant also thinks that human beings are a weird kind of creature. He thinks that unlike other mammals, or anything else, except if there are divinities, we act for reasons. And so we have to take a first-person perspective on our own actions, on our own life, not just a third person, not just the scientist's perspective. We have to ask ourselves why we do things and to note that we do them because we think there is a sufficient reason to do them. We may be wrong. The number of things I've been wrong about where I thought there was a sufficient reason to do it, and I was dead wrong. I mean, that would take us a long time. But what I'm never doing from my own perspective is just being pushed around by a causal chain. I'm always acting for what I take to be a sufficient reason. Now, Navin and Wasserman say that the mere fact that children have treatment preferences is a reason to support pediatric assent. And they go on and talk about considerations of liberty and respect for persons provide defeasible reasons for granting the preferences of children of all ages, in much the same way as they tell in favor of granting the preferences of adult patients who lack decision-making capacity. This is obscure to me. I think, however, it can be clarified by bringing in Kant's thought. What Kant says deserves respect is what he thinks of as the capacity for acting for a reason. He doesn't think that merely having a preference, as I say, my dog has preferences. Kant does not think that there's any reason to accord respect to my dog. But a human being acts for reasons, and their preferences are not just blind urges. And that is something that Kant thinks deserves respect. So, for a human being, the capacity for agency, acting for a reason, is thus a rational capacity. Now, this is my proposal. That's why it deserves respect. Now, I'm going to defer to all of you who are pediatric clinicians and researchers, pediatric researchers, with how far children at different ages do, in fact, have this particular rational capacity, how far they're capable, not just of being pushed around by causal chains, but with acting for what they take to be good reasons. We all know, as I say, anybody who's raised children knows that children's reasons are often not good reasons. But there's still a difference between the dog that doesn't act for a reason and the child that says, this is why I want to do it, even if the why, what comes after the why, is something we should not grant. To the extent that this is a sufficiently developed capacity in a pediatric patient, then I think we have a reason for thinking about why it is we want at least to pay attention to what the child is saying in thinking about the ultimate medical decision. Let me now turn to the concept of authenticity. The capacity to have a project is a very complicated rational capacity. This is certainly not just reducing to a preference. You have a project, you have a life plan, because you think yourself to be justified in having that project or life plan, something that extends over time, that you plan over time, like a promise. Promises are very puzzling because you say today that you promise someone that you're going to do something in a week. Nietzsche goes to great lengths to say he doesn't understand how this is possible. How could you bind yourself today with all that could possibly happen between now and next week? How could you possibly say you will definitely do that thing a week from now? That just seems bizarre to him. A project is also complicated because it also extends into the future. And then it structures your life. And it is often, many people have multiple projects, but they're part of what gives your life meaning. Do children have projects? Do pediatric patients have projects? That is, do they have the capacity for authenticity? Again, I'm going to defer to clinicians. But I do want to note something here about a feature of the literature on triage standards in scarce life-saving resource situations. Now, in such situations, one might have thought that all other things being equal, the morally proper thing to do would be to give the scarce life-saving resource to the youngest child, assuming everything's equal, that all ages of people are equally vulnerable and so forth. You might have thought that the thing to do is, as philosophers would put it, maximize the number of life years that you would save by saving the youngest children. In fact, in that literature, there's a considerable controversy because an argument is made by some writers that priority should be given not to the youngest children, but to adolescents. These writers urge that priority should be given to those who are capable of having projects. The thought is that 3-year-olds don't have projects, 12-year-olds might. And then the further thought is, it's worse to lose your life when you're in the process of gaining meaning in life, process of formulating and pursuing projects, than it is to lose a life when all you have are, in effect, a set of desires that don't have a certain coherence to them. I don't want to try to resolve that question here. That's for another time. I bring it up to note that the premise of this debate is the thought that at least some children, and again, I will defer to clinicians as to where this capacity for authenticity actually starts to click in and to develop, but that some children genuinely have this capacity, and therefore they have something that is, again, the basis for why we think it's okay to give adults the right, say, to refuse treatment. Now, if we want examples, I suppose we could imagine variants of the graduate student and the Jehovah's Witness. So here's 6-year-old Jack. He refuses a vaccination but doesn't give any reason, just says no or I don't want it. Where 6-year-old Jill refuses the vaccination but says that the vaccination will make her arm hurt so that she won't be able to play baseball that afternoon. Then she gives a reason. Similarly, 12-year-old Jack refuses chemotherapy, simply says, no, I don't want it. Jill says, well, chemotherapy is going to undermine her ability to play baseball and to do music for a long period of time, and that's why she is refusing it. Again, it's a matter simply of giving a reason. We can, of course, hypothesize that Jack has reasons that he doesn't articulate, and that would be fine. But what I want to bring out is that, and this is really to wrap things up, if we're to understand why it's actually important to listen to kids when they talk about their medical treatment, it's not just because they are beings with urges like any other mammal. It's because, in fact, they are little human beings. And what's distinctive, among other things, about human beings is that when we act, we do so for reasons. Some are the reasons that are tied to particular moments. I want my orange juice just because it's delicious. I really want a piece of chocolate cake more than I want a piece of orange juice just because it's delicious. But some of my reasons have a different kind of structure. I went to graduate school in philosophy because I thought it was an important thing to do and I could make a modest contribution and so forth. Now, that goes well beyond merely being able to do math and science. And so the criteria for decision-making capacity don't seem to me to actually get at what makes decision-making capacity a relevant and important topic. What makes it important is when it's tied in human beings to our capacity for agency and our capacity for authenticity. And to the extent that a child has some of that capacity, even though the child does not have decision-making capacity, as a matter of the criteria that we use, that, I think, is why it is extremely important to listen to what the child is saying and to recognize that even if you decide that the most important thing is to, impose treatment on the child, there is a loss. The child is being denied something that he or she thinks they have a reason to do. Okay, I look forward to questions in the Q&A. Thank you very much.
Thank you, Dr. Brudney, for an excellent deepening of the language around autonomy and the way that we interact with patients. Now we'll hear from our second speaker, Dr. Erin Paquette.
So I have 3 disclaimers before I start. The first is I'm going to speak from here because, they say break a leg. I took it a little too seriously and I brought my own with me. So they're going to spare me from standing on that for a little while. The second is that I am not a philosopher. I am so grateful for the foundational landscape that Dr. Brudney presented to us and hope to build upon that with some practical application in my world, in the clinical space mostly. But I will say that I am also a lawyer, so we can get a bit wordy, and hopefully I will be able to keep things as succinct and clear as possible. And third is, because I think there is CME for this, I don't have any disclosures, but I do receive NIH funding for projects that are not related to what I'm going to talk about tonight. Okay, so we're discussing this evening how to make decisions for guarded patients. So I started thinking about this topic. Well, who is the guarded patient? An individual who lacks somehow the full capacity to exert their decision-making potential. I won't go into more of what that potential means and the limits of that, because I think we've heard much about that already. But I will say that I thought about this in 3 ways. One is a patient who lacks autonomy. So this includes children, adolescents, and I think a special category of children being those who are state dependent. The second is a group of people that are unable to fully express their autonomy. So this may be an adult who had capacity and then lost that capacity, or that capacity is diminished in some way. And then the third is a group of individuals who may have full capacity but have their autonomy constrained in some way. And I'll say a bit about one group of those individuals, incarcerated patients. So that's kind of the general framework. And being that I am a clinician, I like to start with, well, what are the questions I'm going to help myself figure out the answers to the different types of patients that I'll see. And I'm going to approach each of these groups thinking about 3 questions with respect to decision making. The first is authority. So who ought to have decision-making authority in the case? And I'll present cases of each of these groups. Second is what guidance, what substantive guidance should inform decision-making for these groups? And to whom does this guidance apply? The patient or the decision maker or both? And the third is what are the principles of intervention? Under what conditions would it be justified and actually maybe required for third parties to intervene on the authority, the designated authority to make decisions? So before we turn to the cases of those who have limited capacity, just to start with the autonomous adult, and to give an example of thinking through these cases. So the authority for making decisions in the autonomous adult is the individual patient. And as was pointed out, we think not only about the patient's ability to express a preference, but for that preference to be based somehow in rationality, some reason that makes sense, that's consistent with their value system. Second, the guidance for these autonomous adult patients is what's called a pure autonomy standard. So they are able to express directly what their preferences are. And third, intervention only happens with these groups of patients when there's some evidence that their capacity has somehow been impaired, so that they lack the ability to fully express that autonomy. They become that second class of patients that I referred to. So to move us along, I first want to think about the case of decision-making for minor patients. And I want to start with this case. 3 siblings, Jasmine, who's 12, Malik is 10, and Jarence, who's 8, are diagnosed with a lysosomal storage disease known as Hurler syndrome. They are referred to a center for bone marrow transplant, which is the only curative intervention for this syndrome. And it's known to be the best symptom control, potentially to abort progression of this disease. During the pre-transplant workup, the physicians note that the youngest sibling of the group, who is unaffected, Michaela, who's 6 years old, is HLA identical to all 3 patients, making her a good match for all 3 patients. And the parents are keen on pursuing transplant therapy for all 3 of these patients. So in this case, we want to ask first, who has authority for decision-making in this case? How many of you think the parents are appropriate decision makers in this case? How many of you think they're appropriate decision makers for the 3 affected children? The 1 unaffected donor, potential donor, and all of them at the same time. Right, so that last question seems to get a little bit more, touchy than if the parents were either independently making decisions for the 3 affected children or the 1 unaffected child who may be a sibling, who may be a donor to a non-sibling patient. And so this case, I think, questions our general sense of parents as the natural decision makers for their children, because a parent can sometimes be conflicted in determining the interests for different sets of their children, and those could all be health interests, as in this case, or they could be the health interests of one compared to the educational interests of another that might be compromised while the parent is trying to make health decisions for their one child. So the questions that we have to ask ourselves are, what should be guiding these parents in terms of their decision making? In most cases, for pediatric patients, we expect parents to make decisions along what's called the best interests framework. And we need to question whether that applies in this case. And then the third question of intervention, I'm going to leave for us to get to in a moment. So we've talked about the parent being a decision maker, but in this case, the parents may be compromised to make decisions for all children at the same time. And so we may seek a legally authorized representative or some other decision maker to ensure that the interests of all children can be represented. Second, we asked about the guidance principle, and I stated that in most cases, we turn to the best interest principle. Many of you who do ethics consultations probably refer to this concept when you're doing decision making for pediatric patients. But the best interest principle has been delineated in many formats. And one of the reasons for that is that it's not clear what the best interest is. Is it one singular interest? Is it trying to optimize all the interests of a single child? Is it trying to optimize the interests of multiple children in a family while ensuring that the child with a health interest has that health interest adequately addressed, even if it might not be the best health option for that child? So different individuals have tried to reframe the best interest principle or describe it in ways that help us understand how it may be a bit limiting. Lainey Ross has written about constrained parental authority, which she describes is a range of allowable parental decisions that at least adequately meet the needs of the child with a health interest at stake, but at the same time recognizes that the parents may have competing interests in the way of other children or other interests in their own lives that need to be balanced with the health interests of this sick child. And so the full decision-making authority of the parents to just make whatever decisions they want is somewhat constrained by needing to make at least an adequate decision for the health interest of the sick child. Johan Bester writes about the best interest, all things considered standard, which is a very similar framework to the constrained parental authority standard, in which he argues that we can't necessarily pursue a singular best interest for every patient because there are practical considerations that limit the ability to fulfill that best interest in every case. And then when we begin to think about intervention and think about the threshold for intervention, we have to ask, what are we going to hold parents to or legal decision makers to as good enough decision making before we would allow intervention on that decision? In most cases, while we talk about needing to meet the best interest standard, we don't actually take parents to court over not making the single best interest choice for their child. Instead, we're often reliant on a different guidance principle, which is the harm principle. And this was formulated by Doug Diekma, which articulates that we should only intervene on parental decision-making when the decisions made by a parent rise to a level where there is more harm than benefit to a child. So when the burdens or the risks of not pursuing a particular health intervention are going to outweigh whatever interests the family is trying to pursue, that is the point at which it is legitimate, and in the case of pediatric patients, actually obligatory for the medical team to seek intervention in some way. They may seek this through the court system. They may try initially to do this through what's called nudging, or trying to move parents to the proper decision, even if it's not the one that they've articulated is most in line with their interests. So in the case of the 3 siblings who need a transplant, it would likely be the case that a different decision maker may need to be promoted or appointed to help with guarding the interests of the youngest sibling, who would be the donor, and ensuring that her interests are considered and balanced relative to the interests of her siblings. I want to move this into another complexity in the pediatric setting, which again was alluded to, which is how do we deal with adolescent patients? So while adolescent patients, just like younger children, don't have full autonomy to make their decisions, they have developing or emerging autonomy. They're beginning to form life plans. They're beginning to base their preferences in long-term goals and have potentially more rationality aligned with how they frame decisions. So imagine a 15-year-old patient with relapsed AML who's refusing additional chemotherapy or life-sustaining therapies in the ICU, who comes into the ICU with respiratory failure. And when you go into the room she's you're being called into the room to see her as she's in respiratory distress. Her parents are begging you to intubate her, and she can't talk because she's sick, but she's vehemently shaking her head no. How many of you would respect the wishes of the adolescent patient in that case? How many would give parents the ultimate decision-making authority? So still most would fall to deferring to the parents who are the legal decision makers for this patient. But there are a few of you who raised your hand in that you would respect the 15-year-old's refusal. And I think that intuition to respect that refusal comes out of understanding that a 15-year-old patient who is potentially able to articulate good reasons for not wanting to be intubated, for not wanting to pursue further treatment, based not only in maybe what they expect from that treatment, but prior experience. This is a patient who has relapse disease, who's had life experience that helps to inform their decisions. And in fact, even children as young as 3 who have gone through very serious medical illness have preferences that are oftentimes grounded in reasons that a 3-year-old who didn't have similar medical experiences would be able to articulate. And so both to give attention to their experience as well as to their age and the growing autonomy that comes with that age, I think it becomes a little bit harder to defer, just blankly to defer to parents in this case. And what about state-dependent children? So these children raise a number of other complexities. I've given you here a brief case of a 4-year-old in the foster care system following suffering abusive head trauma during her infancy. Who determines this patient comes into the emergency department, needs to be admitted to the hospital, and ends up needing to be placed on a ventilator for pneumonia? Who determines this patient's interests? She's living with foster parents, but her parents don't have custody of her anymore, but they're still in touch with the foster family and they're still interested in their child. How many say the foster family should be influencing the decisions? Couple. How many say whoever the state agent is, the Children's Services Authority should be making the decision? A few people say that. And how many would want to involve parents in the decision making, or biological parents? Several of you. And while it's legally the case that in the setting of state-dependent children who are either in foster care or kinship care, while the state agent is legally the decision maker, from an ethical standpoint, when you're determining the interests of that child, oftentimes the parents have some knowledge or some sense of what those child's interests are. And I would argue that in this case, whoever has the best knowledge of the child's interests, preferences, likes, dislikes, potential for suffering while receiving medical care, those should be the individuals that are helping to inform what decisions happen with that child. So in each of these cases, we can see a little bit, there's a little bit of a leaning towards who the legal decision maker is. And I think that's quite important. I'm a lawyer. I would, ultimately probably defer to that legal decision maker as well. But from the standpoint of really recognizing, who can make the optimal decision for a child, we need to think about who is best situated to determine all of those child's interests, whether they're health interests or otherwise. Several of us gathered last year in a symposium to think about, just take all of what we know about pediatric decision making, put it aside, and start from basic ideas, basic principles. How should we make decisions for children? And we came up with these 6 ideas that should guide pediatric decision making. People much smarter than I, including philosophers such as Mark Navin, who you heard about in the last talk. But we discussed that parents should be presumed to have wide decision making authority, but not unlimited, to make healthcare decisions for their children. Second, that parents should protect and promote the health interests of their child, but at the same time need to balance practical constraints and other important obligations and interests, both for that child and potentially for other family members. Third, a clinician's primary responsibility is to protect and promote the pediatric patient's health interests, and that clinicians' recommendations in this regard should be informed not only by their own personal values or thoughts about decisions, but by their professional judgment that is informed by the best available evidence present. Fourth, to respect children and promote their well-being, clinicians and parents should inform pediatric patients of salient information and invite their perspective to the degree that doing so is developmentally appropriate. This tenet we thought about quite a bit, and whether this should state that should participate in decision-making to the extent feasible, and elected not to write that because in many cases, despite the desire to invite the ideas, reasons, and perspectives of children, ultimately you can't defer if the parents legally are the decision makers and make a decision that goes in another direction, and that we should encourage clinicians to invite participation to the extent that it's invite perspectives and to the degree is developmentally appropriate, but not necessarily to ensure that participation will occur. And that may be something that we can debate in the discussion session. Fifth, that in addition to state mandated reporting requirements, clinicians should seek state intervention when all less restrictive alternatives have been exhausted and a parental decision places the child at significant risk of serious imminent harm or fails to meet the child's basic interests. Note that this doesn't state that it fails to meet their optimal best interest, but that it's not even adequate to meet their basic interests. And that finally, clinicians and parents should collaborate in a shared decision-making process to promote the child's interests. Okay, I will be happy to talk about any of those basic principles when we move into discussion. But I want to move into the second category of patients, which is the group of patients who have diminished capacity in some way and so are not able to fully exercise their autonomy. And we'll start that discussion by thinking about this case. So Henry, who's 87, was diagnosed with a serious illness that may require surgery. He had been diagnosed with mild dementia, which the family thinks has gotten worse. He's hesitant about undergoing the surgery when it's presented to him due to the associated risks in the recovery process from the surgery, and he refuses it. The patient's family wishes for the surgery to be done and ensures that they will be there to support the patient throughout the recovery process. The patient subsequently agrees to the surgery. When the surgical resident returns 3 hours later to obtain consent documentation, the patient again refuses consent but cannot articulate why he doesn't want surgery. The family still wishes for surgery to proceed. How many of you think it would be appropriate to proceed with surgery? How many think it would, maybe one or two? How many think it would not be appropriate to proceed with surgery? Several of you, okay. So again, we'll start and work through each of these 3 questions for this case. So who has the authority in this case? You have an 87-year-old patient with mild dementia who articulates reasons at one point for which he doesn't want surgery. When he's reassured by the family that they'll be there to support him, says, okay, I'll have surgery, and then changes his mind later but can't recall the reasons. Do we think this patient has full capacity? How many think yes? How many think no? Yeah, so it seems like this patient's capacity may be impaired in some way. And I think the question is, do we think this patient has sufficient capacity to make this decision, or does a legally authorized representative or surrogate need to be identified for this patient? And let's start with the idea that this patient may have sufficient capacity. And one way to think about this is we saw 2 points for this patient. One, when the team first came and asked about the surgery, and then the patient got reassurance from his family and said, okay, let's go ahead and proceed. The second was several hours later, maybe into the evening, and the patient maybe didn't recall all of the elements of the former conversation, can't recall the reasons why he didn't want surgery, but states that he didn't want it. In general, if you approach these cases by thinking about multiple time points, are these patients' preferences consistent at those time points? It can help identify whether this is really a sustained preference that the patient has, or is born out of some fear, perhaps, of not being able to get through the recovery, and then when reassured again by the family, may change their mind back to having the surgery. So I think I didn't really give you adequate information in the case to answer whether it was appropriate or not to pursue. But these are the kinds of questions that we might think about asking as we're helping a clinical team to think about whether to respect the patient's refusal or to seek a surrogate decision maker. If they do seek a surrogate decision maker, we're then faced with thinking about what should guide this surrogate decision maker in making decisions for this patient. In most cases, for patients that who had capacity at one point, as we would presume this 87-year-old had at one point in his life and was able to make autonomous decisions, that patient may have at some point expressed some ideas around what they would want when they were older and unable to make decisions for themselves, in what situations they might want to pursue medical interventions, and what situations they might not want interventions. And if that patient had capacity, then we would expect their decision maker to make decisions based on what's called the substituted judgment standard, which is attempting to place yourself in that patient's position and identify what that patient would have wanted done in that situation. And we would hold the surrogate to making the decision consistent with those preferences. If a patient never developed capacity, say the patient was an adult, and normally we said we would turn to an adult to make decisions for themselves. But if it was a patient that had some congenital disease that resulted in some lasting cognitive incapacity, and they never developed full capacity to make decisions, then we would not have identified that individual's preferences as an adult or even nearing an adult. And so we would revert to the standard for decision making that we use for pediatric patients, which is the best interest standard. And we would expect a surrogate decision maker, even for an adult patient, to ask what's in that patient's best interests in making the decision. Shouldn't be informed by the surrogate decision maker's values and preferences, but rather by the values and preferences that might be important to the family that raised that patient and that patient's overall interests. So when considering benefits and burdens of different interventions. What do we do when we want to intervene, when we don't think the surrogate is employing the appropriate standard? This can happen in a couple of different scenarios. One could be that there are different theories about what the patient would have wanted, and the surrogate is not considering all of those theories in making a decision for the patient. Another situation might arise in which the surrogate is attempting to place their own values or preferences on decision-making for the patient, rather than trying to figure out what that patient would have wanted or what was in that patient's best interests. So I'll give you this case example as one way to demonstrate that. So we had a consult similar to this, an adult patient who had an appointed legal guardian when they went from being a minor to being an adult, and the parents were no longer default decision makers. A legal guardian was appointed because this patient didn't have capacity. The surrogate refuses blood transfusion because they are a Jehovah's Witness. They have no knowledge of the patient's wishes, and the patient never developed capacity. So who would follow the surrogate's decision in this case?
Who would follow?
Who would follow the surrogate's decision to not transfuse? Would anybody follow the surrogate decision maker? Doesn't seem like it. Who would just transfuse as the clinical team? Just transfuse, thinking that that is what the patient needs and providing that to the patient. So few, and I'm hearing some maybes.
Administrative consent.
Administrative consent. So who would go and seek consent either administratively or to a court? So most of you would think that this is appropriate for court intervention. And I just want to note that it's important to distinguish the adult case from the pediatric case in this setting. So I tell you, this is an adult patient. If this were a pediatric patient, you can take, if there's imminent threat of harm, you can take protective custody of pediatric patients, and you're actually obligated in many state mandated reporting laws for potential neglect, because you would make pediatric report of neglect in this case to seek ongoing decision-making authority for this patient. You could take protective custody of the child for a period of time while you were seeking that consent and do what you thought needed to be done urgently for the child. For an adult patient, you would need to seek administrative, depending on what state you're in and what the procedures are, you would either need to seek an administrative, sometimes it's a judge, sometimes it's another administrative individual through the Department of Family Services. Other times you would go to a court and have a judge order a court order specific for that transfusion, or to appoint a different decision maker for the patient's course specific to this medical condition. You can, as any provider, if it's an emergency, say the patient were like literally hemorrhaging in front of you, you can apply an emergency exception and do what the patient needs in that emergent setting, and then seek the administrative support or court order following that. So this is a situation where it's a little different when it's a minor versus an adult patient. But in a case where you don't feel for an adult patient that a surrogate is doing what the appropriate standard is for that patient, then you should seek some authority outside of that surrogate decision maker to make decisions that are appropriate for the patient, either by substituted judgment or by the best interest standard. And I'm going to move on, I think, to our third category, because we talked a little bit about waxing and waning capacity, which was our patient from the original case. And I think the most important point that I think about with these patients are repeated interactions with them to identify when their decisions are authentic, as we heard earlier, when they're sustained over time, when you, and when even if you come like 6 days in a row and the patient tells you consistently in the morning when they seem to have greater clarity about things, they can articulate reasons, they give you the same decision. And then in the evening, many patients have, they working into the evening hours, more dementia symptoms become unmasked. Patients get a little bit more confused and maybe less able to articulate or even identify what their preference was 12 hours ago. So we think about kind of making sure to have repeated touch points to help with decision making in that case. And then finally, I want to spend just a couple of moments talking about the incarcerated patient. So Melanie is a 24-year-old pregnant inmate who delivered a healthy term baby via C-section, complicated by adhesions from prior abdominal surgery. And because of that, required a long time in the OR, a lot of kind of dissecting, moving things around, having pretty significant pain following that procedure. she's discharged from the hospital and with the hospital pharmacy giving her a prescription for 12 tablets of hydrocodone, an opioid pain reliever, but the prison pharmacy will not fill opioid or administer opioid pain control prescriptions. So again, we'll think about in this case, where does the authority come from? What should guide decision-making? And when should you intervene on those decisions? So this is a situation in which a patient's autonomy is constrained, not by their own capacity, but by the legal status that they have in prison and what that affords them in terms of medical options. So the authority for decision-making or the prescriptions for the patient or what the patient will have access to in the prison setting is going to be the physician or provider, practitioner that services, takes care of patients in the prison setting. Guidance is ostensibly supposed to be standard of care that the patient would receive if they were presenting to a facility not in the prison setting. But in reality, what ends up occurring is that there is this standard that physicians or providers must violate in order for a person who is incarcerated to intervene on their decision-making or what they're offering in terms of medical options. And this is called the deliberate indifference standard. So the provider would need to be deliberately indifferent to the patient's suffering of pain in order to succeed on a case where the patient's only remedy is to sue for negligence. But the negligence standard here is not the normal negligence standard that applies in medical malpractice cases. It's this deliberate indifference standard. And you would, in order to succeed on such a claim, you would have to be able to prove that the provider were basically offering no pain relief option for you to succeed in saying that that provider was being deliberately indifferent to the suffering of pain, and that violated Eighth Amendment rights to not have cruel and unusual punishment. So it's quite difficult, particularly for pain control in the jail setting, for individuals to prove this standard and obtain pain relief that is anything outside of general over-the-counter analgesic medications. You can, and there are several challenges that I think physicians that practice in this setting have. They have these dual loyalties, one being to the patient, that patient-physician or patient-provider relationship still exists, and the physician for adult patients, just like pediatric patients, ought to put the patient's well-being in their highest regard in terms of decision-making, and ought to be striving at the very least to do no harm or for non-maleficence towards the patient. But they're also tasked with stewardship of sometimes very scarcely available resources and medications in the prison setting, as well as needing to be responsible if things like opioid use disorder develop in patients that are in prison settings where the rates of opioid misuse are higher than in the general population. And we can talk lots about why that may be the case, but clinicians who are practicing in this setting have to practice in that reality. So they have this tension that really causes a lot of moral distress for prison healthcare providers. And finally, they have these dual loyalties in terms of privacy towards the patient, as well as disclosure to prison authorities, health status or health information about a patient. And so for all of these reasons, even while incarcerated patients, if they were talking to you or I, may present to have full capacity, they have nevertheless constrained autonomy in their setting, in the prison setting. And with that, I'm going to wrap up my approach to thinking about decision-making for guarded patients. I'm not sure if I overran my allotted time, but I think we can move into questions now.
Thank you very much for your talk. You were right on time, no problems at all. For the questions, there are some cards in the middle of your table. If you need a pen or something else, please raise your hand and we'll bring you one. Otherwise, we'll come around and collect the cards. So if you would bring them to the edge of your table, or if you have them, we'll go from there. I'd like to start with a question, if it's okay with you guys. You talked, Dr. Paquette, about how parents have some opportunity to influence the care of their children by making decisions that they think are in the child's best interest. But inevitably, those values are somewhat determined by the parents' beliefs and preferences. Could you both, maybe you first and then Dr. Brudney, comment on how that parent's version of what an authentic child might look like, or the parents' perception of what they think their life ought to look like, how much should that be allowed to influence what's put upon the child, and where would you intervene?
So I will answer that question in two ways. The first is to say, I think that how much you would allow the parents to determine what happens and how much when you would make intervention depends on two things. One is how well aligned the parent's decision or preferred decision is with the child's expressed preferences, meaning if they're on the same page about things, whether that's informed by the parents' values or not, is not necessarily of concern. I think where the concern comes about is when a child and a parent want different things in terms of a medical intervention. And I think a lot of what you will then subject a child to depends on the second thing that I think guides, which is what is the burden of the intervention? What is the prognosis of the child's state, and what is the potential for the benefit of that intervention to achieve its intended end. And so we'll see a lot of times, and I have argued previously that when the prognosis for a child is good, we will push further in terms of what we will allow a child to experience based on their parents' preferences than when their prognosis is poor. When the prognosis is poor, or a child's been exposed already to a lot of therapies that have been burdensome, I think we really try to work from a clinical standpoint with the parents to align them with their child's expressed interests, as we found that many times parents do get there, even themselves, with agreeing with their child, but they're fighting two different things. One is trying to meet their child's interests and goals, and the second is what we face it many times is the parent, the child is refusing life-sustaining therapy, and the parent is grappling with the loss of their child and trying to honor their child's wishes. But when the prognosis is poor, we often will get families to work with us. Not always, but often.
It's a complicated dynamic.
Yes. I'll pass it to you.
I guess I don't really have anything to add. That all sounds quite sensible. I would just sort of ask Dr. Paquette whether in the background is some notion of what is reasonable to be done in the circumstances where that can constrain parents who want to move forward when it does not seem as if that makes sense, but equally, and perhaps even more important, can constrain parents who, when you do see the possibility of benefit to the child, and the parents perhaps are so exhausted and so distrustful of the medical system that they're not eager to go forward, whether you would, if necessary, even go to some form of external authority, a court or whatever, in order to push forward with the treatment.
That's a great question. As to the, I'll take the second one first because I think it's easier. I think in the second case, we're actually obligated to move forward with seeking external authority when a parent is refusing what has the good potential to be life saving for their child. And so in those cases, we would first try to nudge the family in the direction that we think is appropriate. But if they are refusing, then we will many times move to seeking external authority to move forward with the intervention. I find we have the flip side more often, where we have children that are, meeting their last days with whatever illness they have, and they have come to accept that they are dying from their illness. And like I said, Myra Blue Langler, if you've not read it, The Private Lives of Dying Children, I recommend it to you. She's an anthropologist, is a medical anthropologist, an ethnographic study of children on a cancer ward. And this is where some of the literature that's followed from this have shown that kids as young as 3 know that they're dying, even if you don't tell them. And oftentimes will play roles where they pretend that they don't know because their family is not ready to know that they know. But anyway, sorry, I kind of got a little bit of a side of the question. The reason I say that is that when parents are wanting to push forward so hard with therapies that we don't expect to be successful, we will try equally hard to move families to, abandon their desire to pursue those and not burden their child. And we haven't had to go to court yet in that direction. But if anybody followed the Charlie Gard case in the UK, and that was a case of an infant child who had mitochondrial disease, metabolic disease, that basically they had significant impact on their neurocognitive development and wasn't going to regain any of that, did not meet criteria for brain death, but was severely neurologically impaired. And the family wanted to bring the baby to the United States for treatment. The doctors in the UK actually took the parents to court to remove the child from life-sustaining therapies on a claim that what was in the best interest of the child was to stop with pursuing things that were not likely to change their state in any way and only prolong their living in this state where they weren't sure what the child was experiencing, but didn't seem to experience any benefit or any quality or enjoyment out of life. Now, our legal standards are a little different, and our deference to families a little different in the United States than in the UK. But I think that's an example of an extreme case in which the clinicians really felt the parents were trying to put the child through too much and took it to higher authorities.
There's a question here asking about in the end of life scenario, when the patient is no longer decisional or has never been decisional, what are the thought processes and ethics to consider when a family or guardian goes against the previously stated preferences or directives? So I think this is a question about when a family or POA goes against the patient's previously stated wishes, how do you reconcile that? How would you take that from either the standpoint of respecting the patient's authenticity?
I guess a lot depends on whether you really do think that the situation is the one that the patient had previously envisioned. It's one thing for the decision maker to say, the patient had said, please do everything, where they didn't really understand what everything might mean. And where now doing everything might mean keeping the body alive when the patient has no cognitive function indefinitely. It is, I think, a different thing if you have a patient who you really are confident totally got it and actually said very clearly, okay, as long as I'm not literally, meet the criteria for brain death, keep me on life support forever and ever and ever. never take me off. I think that's surely an unlikely scenario, but if that's what's going on, then I think you have a case where what looks like what counts for the patient as the thing which involves their beliefs and values is actually not in their best interest. So the thought that I was trying to develop was that generally living a life in accordance with your beliefs and values is in your best interest. That's part of a good life, but not necessarily in all cases. It is, as I said, a formal feature of a life that is lived in accordance with your beliefs and values. And if
Dan,
in a
it's
rare
hard to hear
case,
you.
if in a rare case, thank you. In a rare case, those beliefs and values are sufficiently unreasonable so that it is fairly clear that your life, or in this case, your passing away, would be better if you didn't obey your instructions. That I think would be the right thing to do. It would be a rare case, but I think it's at least conceivable.
I completely agree with that. The one only thing I would add is that even in the case of brain death, there have been a couple of court cases where a family member has sued a hospital system for discontinuing life-sustaining therapy after a brain death diagnosis, arguing that the patient's advance directive stated do everything in all circumstances, and my family member wouldn't believe in the concept of brain death or wouldn't accept it, so would still want everything done. So sometimes advance directives can be quite powerful in influencing decisions, but I think you really articulated the main concepts and thoughts to think about how much can we attribute what's in the advance directive to the situation we see before us.
A lot of what I'm hearing in these answers is that you have to go a little bit deeper and that there's some extra guidance that's required. Can you both talk about the role of counsel as the basis for decision making and informing that role either as a physician or as a guide to what a good life might be?
Do you want to start with that?
Sure. This is where I think the concept of shared decision making, and if we are not talking about dealing with the patient, or if it's a surrogate situation, dealing with the surrogate, sort of is a label that conceals more than it reveals, because there's many different ways of sharing the decision, and there is, so the spectrum runs from thinking that the clinician's job is to help the decision maker with values clarification, whether it's they're talking to the patient who's going to make the decision and helping the patient to clarify his or her values, or talking to the surrogate decision maker about the patient's values. And the other end of that spectrum is challenging those values. Is saying, well, have you considered? Are you sure that? Have you thought about, here's a reason why maybe this isn't a great idea? And of course, as you move down the line there, you're starting to move away from the patient decision-making model to back in the direction of the physician decision-making model. And I think every clinician is going to have to figure out case by case where to strike that balance with this patient and with that. To revert to what I started with, this is what Aristotle called practical reasoning. And Aristotle had a picture of the person of good practical reasoning who knew what to do in the particular case. And the Greek term for that was the phronimos. And I think clinicians are striving to be that person. And I don't envy them their task. I think it's important and very, very difficult.
I had to give myself 2 minutes to think about this question because when you said counsel, my mind automatically goes to legal counsel. And I was like, okay, I don't usually invite the lawyers into these discussions. I agree. I think it's the shared decision-making model that really does guide how much counsel we provide to patients and families. And I would say that one other aspect of that kind of pushes a little bit against the limits of counsel is that, decision making is constrained by what is offered by the clinician to the patient and family, so that, to the extreme level, counsel is provided by not putting something on the table for a decision to be made about. And the frameworks for shared decision making usually start with the notion that only medically reasonable options should be put on the table for patients and families to make decisions. So there is a little bit of judgment that goes into decision making, before the decision even begins to be made or put forth to the decision maker.
The opportunity to limit those options, what's put on the table to make decisions between, is one of the more challenging parts, and understanding where the patient's preferences are in the beginning is a very complicated part, but making sure that you can achieve a reasonably stated goal, I think, is important.
I think it gets particularly sticky when the decisions are about allocating resources, such as organs, and making decisions about who gets listed for transplantation, because there are a lot of features and factors that go into that decision about when a patient will get listed and that becomes a possibility for them or not. And those are not, at the outset, those are not generally guided by patient and family wishes. They're guided by many external considerations, optimizing how organs are allocated, whether we think that a patient or family would be able to live the expected length of time with, taking care of themselves and that organ to make them a good candidate for transplantation. And so I think that's a big area where the decision is very restricted based on whether or not a team believes in their own values framework that a patient is a good candidate to make that decision or not.
Sure. Dr. Brodney?
I'm glad we brought up this issue of what is put on the table, because Dr. Paquette is pointing out that in some contexts what's at issue is a general sort of public health, general welfare set of considerations, because there's a scarce resource, a manifestly scarce valuable resource in the life-saving organ. But sometimes it's not the case that in any clear way the resource allocation issue is what's going on. But rather, as Dr. Paquette puts it, it seems sensible only to give patients or surrogates reasonable options, medically reasonable options. Now, as a non-clinician, when I hear this in our case conferences, it always rubs me the wrong way, because if you think that it's okay for patients to make foolish decisions, then it's okay, or rather required, to give them foolish options. And presumably the reason that certain options that are not, quote unquote, reasonable are not given to the patient or the family is for fear that they'll say yes. If it were the case that the families were reasonable, you could give them the option and explain why this is not a good idea, and they'd say, okay, we've wasted a little time, but that's all. I think the remnants of physician paternalism remain right there in the constraining of what's on the table, and it may be justifiable, but I think it's not talked about in terms of whether it's justifiable nearly often enough.
I'd like to switch to incarcerated patients for just a second. Does an incarcerated adult who has demonstrated a life plan and authenticity have the right to refuse treatment? Dr. Brudney.
Well, actually, I want to hear what Dr. Paquette says, because this is both a moral and a legal question, and I have absolutely no answer to the legal question, she may. Sure, I do think that it shouldn't matter from an ethical standpoint whether the patient is incarcerated or not. That is, the ethical criteria for thinking it proper to let someone refuse treatment should be identical in either context. Whatever it is that one has given away by committing a crime, assuming one has done it and been convicted of a felony, this isn't among the things that are in presumably in the criminal statute. Well, anyway, they're not. I'll leave that to Dr. Paquette. Ethically, that's not what you've given up, but maybe legally it is. I don't know.
Boy, I had criminal law was like my worst class in school, so this is taking it back for me. Legally, I think actually this is a case on the refusals side that lines up morally with what the analysis is, which is that a patient, a prisoner who's also a patient, does have the right to refuse treatment, life-sustaining or otherwise. I think where it's limited is the flip side, where they can't access necessarily every treatment that would be available to them if they weren't in the prison setting.
Do you think that they might have a claim to those treatments otherwise? Should the care be equitable both in and out of that setting?
Again, I think this is a legal and a moral question. From a legal standpoint, I would argue that I don't necessarily agree with this, but I would say the legal argument for them not having the same claim is that in violating whatever law landed them to be incarcerated, they do lose certain liberties, which include ability to, say, make decisions, travel freely, obtain, care at any institution. Because, a patient who's not in prison also may not have every option available to them depending on where they have access to obtaining care. And so that the same would be true of a prisoner, except that their options for obtaining care are much more limited to what the prison has access to, either within their local infirmary or the hospitals that they are contracted with to provide care to prisoners. Morally, I think, yes, they have the same, I think they ought to have the same claim to equitable care, whether they're in or outside of the prison setting.
Dr. Brudney, would you like to comment?
Simply that I agree.
This is a question for both. At what age is it less of the parent's decision and more of the children's decision when it comes to making medical decisions for themselves? And there's kind of a corollary question that's been submitted. Is it still acceptable to judge a child's capacity to decide or determine their authenticity purely by age?
So the second question I think answer more quickly, which is that I think that age-based determinations of capacity are really not the most appropriate way to determine capacity. It ought to be more based on maturity, the ability to manipulate information, the same kinds of criteria that we look to determining capacity in an adult patient. We ought to think about the contributions that a minor child can make to decision-making based on how well those abilities are developed. Now, to put the age, the other question was at what age, which I would reject the notion of a single age, except to say that we know that brain development in children doesn't occur in childhood alone. It extends into young adulthood, and it's not really until your late 20s to early 30s that most people have completed brain development, particularly around the propensity for risk taking and ability to manipulate ideas for long term rather than immediate gain or consideration. And so I would say it's probably not in childhood when we should be deferring completely to decisions. There are many adults that we ought to be questioning too. And that really we ought to be looking at criteria based in maturity and ability to understand and to manipulate and give reasons for decisions that help us understand when an adolescent might be ready.
I read this one both as a medical question and a parenting question. It seemed to bridge
For
that.
my child, it's always going to be my decision.
I would say 40 is the age. The other thing to say about this is that, we use bright lines all the time. And once we start using them for administrative convenience, we then get other sort of equity issues. So I guess I don't think that people who are 18 years of age, this just goes along with what Dr. Paquette is saying, are clearly capable of rationally deciding to enlist in the military or engage in other kinds of activities where they may no longer have the choice not to be subject to various kinds of significant risk. I don't think that at 18 they really get it. On the other hand, once you let them do that, then it becomes hard to say that at 18 they can't make decisions about their health. It becomes hard to say that they can't vote, and so on and so forth. And so, while if you're asking the sort of question about whether if we could decide everything individually, we would end up using some sort of bright line like 18, certainly not. But insofar as for various reasons we sometimes do need to use bright lines, and then that commits us, just for equitable reasons, sometimes to using bright lines elsewhere, we can be caught in trying to figure out how it's really best to do these things.
There's another question about psychiatric and addictive disorders that can distort the expressions of preferences and the concepts that surround autonomy. Do either of these models for assessment require modification to be useful in these situations?
I guess I'll start. I'll be brave and start. I think that this actually goes to the question of whether it would make sense to change the criteria for decision-making capacity to include something that does go beyond instrumental reason, as I put it. That is, normally we don't quarrel with the patient's values in determining whether they have capacity. We're not supposed to, and I think in a sort of hidden way that sometimes happens. But we could think, for instance, one of the Grisso and Applebaum criteria is does the patient do this thing called appreciate the situation. And usually that is glossed, including by Grisso and Applebaum, and the stuff I've read, as does the patient recognize that a certain medical condition applies to her. But we could ask a different question, which would be a value-oriented question. Does the patient adequately appreciate, meaning really understand all the ramifications, not just in terms of what fact follows from what fact, what will happen if you go down this medical route, what will happen if you go down that medical route, but whether this or that medical route is a reasonable or unreasonable route to go down just in terms of what a decent human life would look like. Now, in that case, if we went that route, then in fact, there might be patients with one or another form of psychiatric disorder who could pass the current standards of decisional capacity who would no longer do so. So I think there are costs to going down that route. It may not be net the best thing to do, but I do think that we, by having a criteria of decision-making capacity that are so rigidly designed not to put values into the equation, we sometimes get ourselves into situations where we have patients who we have to say have capacity, but we think that there's just something amiss there. And we can't quite capture it in those, in the simple criteria that are there.
I would agree with that, and I would say that in practice we tend to kind of, in thinking about whether the patient is rationally manipulating information, like under strict criteria, at least in the cases that I've participated in where psychiatric disorders have come into play, we think about whether they're rationally manipulating that information in line with their goals and values, and not just are they rationally manipulating it in a way that somebody could make a rational argument for the decision that they're making. And if a patient's psychiatric condition leads to decision-making that might be rational in a vacuum, but isn't rational in terms of other stated goals or values for the patient, then we tend to think about, can we mitigate this psychiatric condition in any way to help better align their decision-making process with their other goals and values. And if we can't, we do sometimes have discussions where we'll, question, does this individual really have capacity to make, this decision? For us, it may sound a bit paternalistic, and it is. I practice in a pediatric center, and so where this has come up is in some of our just turned 18 or 19-year-old patients, where we're technically tasked with treating them as autonomous adults, but where depression or severe anxiety over the medical experiences, the trauma that they've gone through, can impair their decision making in some ways. And I'm not sure that our approach would hold water in some adult settings, but in the pediatric world, it works.
Was there something you'd like to add?
No, all good.
Okay. Well, we're almost at time, and I think I'll conclude the questions here for now. Thank you both for traveling here, for talking with us this evening. Thank you for helping us clarify with both of your speeches the way that we use capacity and autonomy and the interventions, the way that each of these criteria interact with each other are very nuanced. And I think you've shown us that tonight, both with your excellent talks and with the questions that dive around the same issues. So thank you very much.